How's the
All
connection
right,
on this
guys.
side?
Good morning. Welcome to 2025. Dave Kittle with me. I'm Tony Maritato, PT Breakfast Club. We are back and we have quite the lineup. But first, Dave, man, how was the holiday? How was New Year's Eve? Like, this is your first big holiday with a baby in the house. What's going on? Can you hear me? You're frozen. Okay. Dave, can you hear me?
It's coming in and out. Just give me a second. I don't know. Got it. I got some technical difficulties. Got a new laptop. We're gonna try to make it through as much as possible. Christmas was wonderful. New Year's Eve was wonderful. First holidays with the baby. Just give me some confirmation if this is coming through or if it's still choppy.
It's choppy, but it's coming through. I can hear you. We're gonna make this
Okay.
work. All right. So big
All
things
right.
for the new
I'm
year.
on a PC, folks. I'm on a different laptop.
No problem. No
We
problem.
got a little technical difficulties.
All right. Let's jump into.
All right.
You had
I'm here.
mentioned.
How's the connection? If you want to get into it, and then I'll try to jump in a little bit later.
Yeah, you're delayed. It's a little choppy, like you said, but um, let's see how it goes. So, I had shared on my Facebook page that I had my
Okay.
first million view reel on Instagram. I grabbed a screenshot. Let me see if I can pull it up here. Um, and this was just totally random. Like, this is one of those deals where I started putting up videos in October. I never did anything with this account. Well, I shouldn't say never. I went back, I looked, I think I had posts from 2020 maybe. And what ended up happening was I was like, I need to get back on Instagram. I need to get back on Facebook. Let me start posting again. And all these are mostly are videos that were on my YouTube channel that I re-uploaded without the watermark. So there's no YouTube watermark on it. I put it on Instagram. Instagram automatically kicked it over to my Facebook business page. And for whatever reason, I know the reason. This particular reel took off and it just kept growing and growing and growing. In about 3 weeks, it hit 1 million views. And so I think a big part of the reason why that reel did so well was because it shows somebody in pain. It shows somebody, a real person, experiencing real symptoms that other real patients who have had a total knee replacement are dealing with. There was nothing instructional in that video. There was nothing promotional in that video. I've got hundreds of these video clips where I'm literally just showing, I've got my phone. I'm recording while I'm palpating. I think people like seeing my hand, seeing the palpation. And in that particular one, I mean, it's a big swollen knee. I touch a spot, he kind of reacts to it. Patients can relate to that kind of content. So first, before I go on, any thoughts, any observations? What kind of goes through your mind when you see some of that stuff?
Well, first of all, congratulations. 1 million
Yeah,
views for one video clip. It's incredible.
absolutely.
So choppy. I'm gonna come in on my phone and let's see if
I
that
think
works.
that's way better.
Yeah.
Absolutely. Way better.
All right. Let's see. Horizontal or vertical? Does it matter?
I think this is better. Horizontal is better. Full frame.
Okay. All right. All right. So, first of all, congratulations, Tony. 1 million views on one video clip. It's incredible. I'm not surprised, but you putting it out there, I'm pumped. I'm pumped for you, and hopefully, this is just the start of many, many more clips that become millions of views or multi-millions of views per video. So I don't want to hold you to it, but hopefully, this will be the standard for Tony Maritato moving forward.
Well, what I think is interesting is this same exact video was on YouTube, not doing a whole lot, and what I'm seeing now, so I'm publishing every single day, usually 3 short videos a day across Instagram, TikTok, Facebook business page. Um, I'm not putting them on YouTube because they're already on YouTube. And I'll hit a video with 180,000 views on TikTok that has like 1,000 views on Instagram. I'll have a video on Instagram with, 1 million views, that one, and it has maybe 10,000 views on Facebook. I'm sorry, there is no rhyme or reason as to what hits on what platform at what time. I even had a video that was on TikTok. It had like 3,000 views. I took it down. I put it back on TikTok, and now it's got 180,000 views. Now, just like patient care, and that's the funniest thing about this. I love seeing lessons that I learn across multiple disciplines that apply in the same way. Just like patient care, there's a therapist who gets a patient, they do an evaluation, they deliver an intervention. The intervention, air quotes, works. If you're listening, I'm doing air quotes. And they're convinced it's because of that intervention that worked. It's not. It was just the right time, the right place, the right person, and that person got better on their own. But now that therapist is convinced that they are the expert. They write a book, they create a course, they go through and name a treatment technique after themselves. We see it all over. Yep. We see it all over the place. And it's the same in social media. When I told somebody I did something, they were like, oh, don't ever do that. You got to do this. And nobody knows. The people who created the algorithm don't even know. We don't know. We just need to experiment. We need to, make our best educated guess and just keep working and moving forward.
Yeah, and I think I don't know, maybe you'll be able to confirm in the coming weeks or months, but like, do you think, Tony, that part of your the why this video got so many views in such a short period of time? Do you think it's the non-promotional part of it? Do you think it's part of because it's like your POV, your point of view, and you're talking over it, and your hand enters the screen, and then you're kind of it's almost as if like the audience is in the provider's glasses or in their brain, um, or maybe something else. Are there multiple features or factors here that like other therapists, other practice owners, providers can maybe model that you think these are some of the reasons why? Or is it just completely like you had to put out hundreds or thousands of videos for something to become 1 million views, and is it completely a lottery ticket, or are there some factors here that folks could maybe try to model and test?
I think we can lay a reasonable framework out to say, yeah, like, okay, the direct point of view, as opposed to a talking head or me trying to educate, being behind the camera as if you're the person doing it. I do think there's an appeal to that. It's not super common, at least in our space right now. I do think that it's a real person and you see a real response. We know how powerful real stories are. And the thing that I see, and I've shared this on a couple posts already, is once I start seeing comments of people saying, that's exactly what's happening to me. That's exactly what the surgeon said to me. That's exactly what, whatever. That to me is confirmation that there's a resonance here between what they're seeing and what they're experiencing. It creates an emotional response. But even with all of that, like, yeah, there are the hero's journey and there's copywriting techniques and there's all this stuff. And you could have the perfect formula, but there's also an element of chance. There's also an element of, I just put it out at a time that happened to be when the algorithm was looking for something to push out. And then there was enough of a community out there that spent enough time watching it and consuming it and commenting on it that it reinforced what the algorithm needed at that moment. So, like everything, it's chance mixed with being prepared and putting those two together at the right time that you get the result. You can't have one without the other. And so I keep trying. I keep trying to replicate the formula and do it, and I've got some that do well and I can think that I can predict it. I've got some that do terrible. And I'm like, what the heck? Why did this not take off? Well, probably timing, probably, things out of my control.
Or is there any common theme with some of the other videos that you might have done like this, where you do kind of a close up on a knee or maybe some other area, the same type of POV where you're talking over it, and the audience can really only see like the knee joint or some other joint? Like, have you done other videos like this? And if so, have they tend to outperform the ones where you're kind of like selfie, your face, and maybe it looks a little, the first impression is maybe like, oh, here's the provider, he's trying to pitch and sell and get patients into his clinic, or whatever. Have you done other videos like this of this same like POV and style?
Yeah, I think it's usually the ones where it's a common. Now, I'm fortunate also in that I've got the total knee replacement group. I hear thousands of people talking. I hear commonalities in what they're saying. And so when I have a real patient in the clinic and they're like, it hurts right here, and the doctor said the x-ray is totally normal, I know that's gold. I know that is going to resonate with the audience because I've heard thousands of people say, why does my knee hurt so much? And the x-ray is normal, and then especially when I can now come in and say, well, because the pain is at the head of the fibula, not at the knee joint. Even though you think it's the knee joint, it's not the knee joint. It's the fibular. It's the junction between the fibula and the tibia. And I go through a little bit of that. But those are usually the ones that I know. I know the ones that are on the edge of being gross. I've got 2 or 3 videos of just nasty, disgusting open wounds with dirty fingers and patients are picking at it. I can't share that because that is too over the edge and it's not going to resonate the same way. But if I have one where I've got like significant lymphedema problems and the patient's like, no, it's totally normal, I can share something like that. It's got to be right at that edge. It's like going to see Friday the 13th or Nightmare on Elm Street. Like, we want a little bit of mystery. We don't want to be completely disgusted. There's a fine line there that I always try to find and navigate. But literally, I was thinking about this the other day. I've got hundreds and hundreds and hundreds of clips like that. 15 to 35 seconds, some maybe just a hair longer, sitting on my computer that I'm just data mining. I'm just going through. I come in the morning, I pull up the folder that has all of these clips and I start going through. I'm like, okay, this one, this one, this one. I might trim the edges a little bit, put on captions and ship it. And I usually schedule those 3 or 4 videos to be published periodically throughout the day. And it's been working. I mean, I already showed you guys, the Facebook page has got 2 million views on Reels in the last 28 days. Instagram since December, mid-December, so about a month, Instagram has grown almost 2,000 followers, which I started with 1,000. So even though it doesn't sound like a lot, that's a significant growth for that channel. And I'm almost at 1,000 followers on TikTok when I started that account November 4th. So whatever it is, it's working.
I'm surprised. Like, I'm not surprised, but I'm curious as to why you wouldn't post those videos that are like a little like disgusting looking or whatever. Like, I figure, YouTube. You've seen what works on YouTube. You got the Dr. Pimple Popper. The whole show is about things that are disgusting. Is it you don't want to attract that percentage of the world or the audience, or you're afraid of backlash where people unsubscribe? Like, I thought, if you have content like that, you could have, an overlay text that says like, don't put dirty fingers in new wound, or what not to do after knee replacement, or wash your hands first before you even attempt to touch your wound or something. Could you add some educational component to it, knowing that it could resonate, but at the same time, are you afraid of some negative backlash with your content, with the algorithm, with the audience, whatever?
I am. I'm afraid of a negative response. I did consider, this was the one thing I was considering, blurring everything with a warning sign saying, if you don't want to see graphic content, click away, with like a 5-second countdown so that they know, okay, in 5 seconds, that's going to increase engagement. It's going to increase watch time. It's going to do all that stuff. But then I go back to, I'm like, you and I are so comfortable and we're so used to this world of seeing this kind of stuff. But to the general population, which is my target audience, we still have to go back to, I don't want a pimple popper channel. That's not what I'm looking for. I do still want to prime the algorithm and get it ready so that when I put video content out there that is selling something, that I get the people that I want to purchase what I'm selling. So I do feel like if I cross that line, I'm moving into, a different population, and that's not really where I want to go. Plus, I don't want somebody to look at that and think that I'm making someone look bad. Everything in what I do is trying to be positive, trying to be supportive, and I want to stick to that. And so when you see something that it's too much, like I watch Kensington Street in Philadelphia. I watch those videos where they're walking by and you see all the stuff that's going on there. I don't want that for my channel, and that's the thing. So there's an audience that I could cultivate, but I don't want that audience.
It makes a ton of sense. Now, just for context, the video that you had that went to 1 million views, it was that one that you were talking about the fibular head, and you were telling the patient, or is that two different videos?
It was a different one. The one that went to 1 million, it looks like an infected knee. This was a patient that had an infected knee. It was no longer infected. They did the antibiotics. They did the spacer. It was 4 weeks post-op. This was a complicated case that I've been working with this patient for over a year when we recorded that video. And so I think, though, I put across the headline, like, no infection, just swelling, I think I said. And everybody was like, that looks horrible. That's a train wreck. That's infected, all of these kinds of things. It didn't bother me. I had no emotional ties to it, but I kind of knew it was such a different looking situation, not gross, but different, that it would get engagement.
Got it. Yeah. So what's the future plans and the steps moving forward? Like, do you have any thoughts on, certain styles like that more often? Are you still going to do your normal mix? You're always going to be testing things, right? So like, what's next for you, your channel, and your content?
My goal with all of this is I'm launching programs right now using some of the new products and the equipment I have in the clinic, targeting very specific patient populations that relate to those videos. So I am looking to attract patients that have had complicated outcomes following a knee replacement. I'm doing a 15-day post MUA program where the clinic is open 7 days a week. So I'm coming in Sunday, coming in Saturday. I'm targeting patients that either want to avoid an MUA or they've had complications with their post-surgical care. These are local patients, but then I'll expand out to virtual and digital, which we're going to talk about when we talk about Larry's article. And the idea is, and I don't know, I'm not an expert in any of this, but it would make sense to me that I'm priming the algorithm with these specific videos about complicated or, challenging post-surgical knee replacements, that when I then do throw something out there, I can put an ad behind it because it's a proven piece of content, and hopefully I can generate sales. I can reduce my cost of, the click and all that other stuff.
Got it. Now, the programs like that, for specifically the manipulation under anesthesia program, is that going to be an insurance covered benefit, or is that out of pocket? What are you planning there?
Both. So anybody local, it's going to be an insurance covered benefit. I am specifically targeting people that have, and I put language out there, that have exhausted their insurance coverage. Now they're cash pay. I have offers for them for cash pay. I am promoting, the fact that just because your insurance is no longer covering physical therapy doesn't mean you have to stop physical therapy. We have options.
Amen. Amen.
Yeah, that's right. Because, the reality is, and of course, I'm leveraging the fact that, hey, I can get you in today. You don't have to wait 3 weeks. I'm working on helping them understand it's more the fear and the anxiety of the upcoming manipulation under anesthesia. That's what I'm helping you work through. That's what I'm helping you deal with, and so I think it'll be a great program. I'll keep everybody posted, of course, but it is very kind of laser focused on that specific population.
Got it. What do you want to move to next?
Let's talk about the article. Let's talk about Larry Benz posted an article, and I have it here. Let me see if I can. How do I get it on the screen?
Yeah,
there we go.
There you go.
Okay, so this was posted through LinkedIn, and I'm gonna kind of scroll around. Virtual health in physical therapy. You know, of course, Larry has a unique perspective. He's been around for a long time. What I'm trying to do is get us, there we go. That's the view I want. And some of his perspectives agree with you. Some of his perspectives agree with me. He talks about the landscape, the digital revolution. He talks about Hinge Health, which he outlined some of the challenges that they were facing and what they went through. They had a planned IPO. He talks about Sword. Some of the interesting things here that I wanted to highlight. You know, he says here, quote, physical therapists are licensed to use hands-on skill, have empathy, compassion, and the ability to think critically. Where I'm going to kind of push back on that is I'm going to say that's true. That's not what insurance is paying me to do. Insurance is not paying me for empathy. Insurance is not paying me for compassion. Doesn't mean that I have to withhold it from my patients, but what it means is that if a patient has the ability and I have the desire, that is a value add. You know, you want therapy to be fun? Hey, come on in. It's $300 an hour. You just want therapy, bare bones, no frills. It's paid for by insurance. Go sit on the bike for 10 minutes. You know, like that is reasonable. I mean, we've given away so much of our value for so long, and it's continued to erode the reimbursement to the point where we got to say, like, look, this is what we're being paid to do. You had a knee replacement. This is the post-surgical protocol. You want something different. You want something better. You want fun. You want to work with somebody who, you know, is empathetic and compassionate. It's more money. If you want bare bones, effectively, I said this the other day. I don't want this to be perceived, you know, negatively. It's basically food stamps for healthcare. It's really what it is. It is the social safety net that is ensuring everybody has coverage, which they do, and they're getting, you know, the minimum standard of care, which is still the acceptable standard of care. Any thoughts on that?
I agree. In fact, maybe on another episode, I'm going to send you a screenshot of. I think it was a female physician. I think it was a Twitter post, but it said something along the lines, maybe a little more aggressively, but it was something around health insurance should be just for catastrophic issues, like, you know, car accidents, major trauma, fall out of a tree, I don't know, major sports injury, whatever. But, you know, it's a whole other conversation, but similar to the theme of what Larry's talking about, where, I don't know, like, it's been used for the health insurance for physical therapy coverage. It's been used for various reasons, whether it's like major complexity or like moderately or, you know, simple complexity. And because of some of those reasons, again, we've talked about it before, whenever the care is subsidized by a third party payer, the more subsidy, typically, like, the more utilization, and, you know, then that utilization that may or may not be actually medically necessary in terms of like truly what the what the insurance is uh, looking to cover and pay for, and then what the therapist is actually documenting. Like, anyway, so we can go more into it.
Yeah. This comment from Jared, I've never heard of this. Flock Health, they're totally AIPT clinic in the UK. Have you ever heard of that?
I've never heard of them. No.
Sorry, Jared. If you have more information, share it. But yeah, it's interesting. Let's go back. Oh, I lost my view. There we go. We'll take this one. All right. So opportunities. Through the article, he goes into opportunities for 2025, hybrid model gaining traction. This would be a situation where we're incorporating in-person with virtual. I think that's huge. I know you and I have talked about it. Your patient population doesn't necessarily want a combo like this, but I do think if you go back and you eliminate the thought that virtual or telehealth means video, email, text, like any kind of digital communication between you and your patient, I bet you're doing something like that. And if nothing else, if your patient asks you a question through text, you reply. That's telehealth. That's a virtual engagement that I think adds value and your patients appreciate. One of the ones that I think is an interesting model goes back to, if I was a mobile therapist, I would go to the patient's home. I do an in-person session, but if I don't have the ability to commute and drive there all the time, I do one in person. While I'm there, I set them up with the digital. Doxy.me still has a free HIPAA compliant version that doesn't require your client to download an app. And so literally, like tomorrow, I do a virtual 1-unit session. Hey, John, how's it going? Let me see you do the exercise that I showed you yesterday. I could, leverage that in multiple ways. I could be with the patient in the morning when they're waking up. I could literally do a wake up call. And with the wake up call, I could see how they're doing log roll, sit to, edge of bed stuff. I could join them in the evening when they tell me they have more pain in the evening, less pain in the morning. It opens so many doors for me. And even though I don't have the quote hands on, I still have opportunities to deliver value. And for those who don't know, Daniel Hirsch and I talked, I published that video. Telehealth under Medicare has been extended to March 31st, 2025. And a lot of people, including Larry here, Daniel, a lot of people expect it to be extended even further. Any thoughts or feedback on a hybrid model of patient care?
So hybrid meaning some in person and some telehealth, check in, and whether that the telehealth part also through a covered service, or those things out of pocket, or what do you like? What would be the definition here of hybrid?
I would say two conversations. First is, who are the therapists who want to do this combination? Second is, do they want to go through insurance or not? I would do either. I'm more insurance based. So yeah, my hybrid model would be, I bill Medicare, I bill third-party payers that are covering it, and I leverage the ability to communicate digitally to the advantage of the patient, to the advantage of my business. You might do it all under cash.
Yeah. I mean, every time that we talk about this, I always want to say like, hey, I live in New York City. I know I live in a bubble and it's different. But even then, like, there's people here that don't pay out of pocket, right? And there's always going to be, again, we talked about it, the social safety net and the Medicaids and the Medicares, and there's we want services to be there for folks that truly cannot afford it. But at the same time, like, as soon as I lay that down as, like, I preface it with, like, that's me understanding the softer side of things. But at the same time, we've had people balk at paying out of pocket, and then, years ago, doing full-time visits, someone balks at the price. We agree, whatever, or they're like, hey, I'll try a visit and we'll go from there, or I'll try a visit or two with you guys until this other agency or Fox Rehab or whatever is ready to take me on, right? And so that's when I
Bridge
said,
visits.
a bridge visit, right? So then I go into the person's home, and they're saying that they want to use their whatever, United Healthcare in-network or their Medicare or whatever the insurance payer is. And you go into the home and you see a whole bunch of new things that people have spent money on. And it's like Amazon boxes everywhere, Walmart boxes everywhere. Arguably, again, I'm not like the judge of how someone else should spend their money, but it's items that, don't help their health and wellness. It's like, I don't know, like a new TV, a new laptop, a new microwave, I don't know, new running shoes. Like, people, it's fascinating. It is so fascinating to see what people spend money on. And those are the things, those observations are the things that have allowed me to continue to push and just be so, confident and, firm with, like, what we do, why we charge out of pocket. And I think we're going to just continue because of multiple things, like whether it's in the news or just things like with healthcare and all that. I think it's going to continue to shift Again, there's the social services, the safety net for folks that like truly can't afford it. There's going to be it's like it's a bell curve. The folks in the middle, this huge sea of people in the middle. I think they're going to continue to get smarter as consumers. That was something Will Boyd pointed out about trust and trust in their therapist and things like that. What are the factors of trust when consumers are shopping around for a new provider or a new whatever it is?
Yeah.
So it's just really fascinating. And you're right. Like a lot of this stuff, I do agree with Larry. It just, I don't know. It's just, it's something I think we're going to continue to talk about. Like there's always going to be some covered services. Then there's going to be, I think, more and more practices shifting away from, I've had someone said, a chiropractor that I know, the insurance teat. So
it absolutely builds dependency. There's no doubt about it. I mean, Rafi said absolutely hybrid care equals access to clinicians, not necessarily heads up, synchronous encounters. Talking about access to clinicians, Daniel and I had a conversation in a second video that I'm going to publish where I said, like, look, I think if business owners are struggling to find therapists to do evaluations and initiate care, they have physical therapist assistants, but they don't have physical therapists. I think there's a case to be made, even in situations where the telehealth is not a covered service, maybe a Medicare Advantage plan that's no longer paying for it. I think it would be worth it to hire a remote therapist to do the evaluation, to comply with State Practice Act requirements, and initiate the plan of care, and then have the assistant who is on site, who is available, deliver the service. And this is a different business model where even if you're not getting paid the money for the eval CPT code, you're gonna at least get that patient started. There's no more wait lists. Like there's all these other things that it's opening the door for. If I have to pay $50 to get a plan of care started or $70 to get a plan of care started, and then I get access to all of that revenue and get the patient going and feeling better, 100% no brainer. So there are models out there. Dana put out a ton of great information here. If we believe in our ability to help patients achieve better outcomes, prevent higher costs, unnecessary medical interventions, we should be pushing to be paid for outcomes. I love it. I'm a big outcome driven guy. I don't want to be paid for minutes. I don't want to be paid for CPT codes. If you want or believe payment will incentivize action, pay me for the action we want. You want patients to get better? Pay me to make a patient better. Don't pay me to spend 8 minutes watching the clock delivering therapeutic exercise.
I love the stuff that Dana puts out and talks about. I just don't think that's ever going to happen. I just don't think it's going to happen. For example, you just said, okay, so you want an insurance company, Tony, to pay you for an outcome. Who's going to confirm that knee pain, that patellofemoral knee pain now is completely fixed, and that patient is no longer going to be in a certain risk pool for that insurance company, and that they only need 3 visits, and if they went to some other place that was fee for service, they would have been there for 12 or 15 visits or whatever, hypothetically. Those are the things, like, it's just, I don't think it's going to happen. Yes, bundled payments, if the insurance company says, okay, for this patient, this age, this risk pool, this moderate complexity knee pain, whatever, non-operative patellofemoral knee pain, we're going to give you a bundled dollar amount, and you can spread it out over 3 visits, 6 visits, 12 visits, whatever, right? I mean, if that were to happen tomorrow across the entire country, there would be significantly less utilization. There would be less visits. Practices would be like, oh, come in for an evaluation, well, independent home exercise program, and you're good. Have a nice life, right?
I don't think that. I think that's an extreme case. I don't think that's what would happen.
I do.
But I understand where you're coming from. Absolutely. And real quick, Dana, when I said it, I knew somebody was going to say that. Medicaid is the safety net. Medicare is not, unless somebody is a Medicare QMB.
Yeah, just Medicaid.
And I get it. I would still say Medicare is still something of a safety net. We're forced to pay into it through our working career. It's not a choice that we're making. And it's, like Social Security, it's one of those things where I would still classify it as a safety net, as food stamps, as an entitlement. But it is what it is. It's a system we live in. It's what we're working with. If we jump back in here, I was a little surprised to see that Larry was talking about remote therapeutic monitoring, and basically, other tools that are out there. He was bullish on RTM, and here they're talking about private equity, and he was saying that a lot of companies are not taking private equity. They're trying to bootstrap. They're trying to do it on their own. Let me see if I can expand that a little bit. Which is going to, kind of limit growth. Basically, you're trying to put, you don't have the money to fund what you need. I find this to be the biggest barrier for therapists, me included. If you don't have funding, how do you innovate? How do you excel? How do you put money into hiring the best staff, into buying the best equipment? And this has been a conversation that I've been talking about a lot more lately, back to beating up on Medicare. If Medicare is paying me the same to use a 20-cent rubber band versus a $20,000 high-tech piece of equipment, I'm going to be incentivized to use the 20-cent rubber band. There is nothing in the Medicare budget that they're paying me that's going to allow me to purchase equipment and innovate and buy nicer supplies and nicer materials and better educate my staff and my clinicians and everything else. So I do think that declining reimbursement not only hurts the bottom line, the profitability, it also hurts the quality of the profession. What do you think about that?
I mean, you're putting this is a softball question for me, Tony. I mean, come on. Of course I agree with that. If you have no margin where you can't do, new advertisement, new promotion, whether it's pay a marketing company, it's, buy a SoftWave, finance it, whatever it is, have the time like you have to record videos, put out content, do different things. Like, yeah, if you don't have margin for that, if you don't have like a business structure or practice that allows for that, yeah, you're getting squeezed. I mean, we already know like owners if they're completely in network, they've been getting squeezed. And then, every year, regardless of the administrations, presidents, whatever, it doesn't matter. There's always going to be an increase in the cost of living, and things are continually going to trend to be a little bit more expensive year over year. And so you still have this payment reimbursement, which is basically the same, if not, less with some cuts. Yeah, practices are getting squeezed, and there's no way around it. It's a challenging situation.
Scott, you are a wise man, but Scott says, a wise man once said, show me the incentive and I'll show you the outcome. Totally true. Like, these are the things that drive me crazy. You're incentivizing me to watch the clock. You're incentivizing me to, provide units, not outcomes. That's really where the business is pushing us. And to your point, Dave, yeah, if you give me a bundle payment, you better believe there's going to be fewer visits that are being delivered. There's going to be fewer units that are being delivered. I would argue though, I still think the outcomes wouldn't be that much worse. I think we're just overutilizing units because we're getting paid to sell units. No matter how much we don't want to do that, everything is pulling us toward 3 more minutes and you can build a third unit. Diversify your units. If you do for AMA guidelines, if you do 8 minutes, you can get 32 minutes, 3 units, all that kind of junk. None of us want to mess with it, but we also want to pay our mortgage and we want to put food on the table and we want to do these things. If we take a look, so challenges for 2025, back to the article, reimbursement obviously continues to decline. Provider skepticism. So after years of reduced reimbursement, increased administrative complexity, many providers are hesitant to adopt new opportunities. AI, anxiety, right? Is Sword going to replace us all?
No.
I did say, now I'm curious to get your perspective on this. I did say, and I do believe, the science behind what we do is a commodity. right? Like the science behind it, the true science. There's not a lot of it, but the little bit of true science we have behind what we do, it is a commodity. I could get it for free. I could get it from AI. That is the stuff that Sword and these other companies, I think, are delivering, and it has virtually no value. There hasn't been a day in my physical therapy clinic that I haven't had a patient mention Sword or Hinge. They're still in my physical therapy clinic,
Exactly.
even though they have access to those resources.
Why?
Because they're here for the empathy, they're here for the touch, they're here for the stuff that technically the insurance isn't paying for, but we are using.
The experience.
Yeah.
The human. This. Okay. Now it sounds like you're agreeing with me with all this.
There's a middle ground. We'll figure it out.
Okay, Ann and I watched a video last night because on our smart TV we watch YouTube, which is hilarious. It's a whole different world now. But we watched a YouTube clip. Barnes and Noble used to be almost dead because of Amazon and the Kindle and all that, and they opened, I think, recently, or they said in 2024 or something. They opened 61 new stores, and every Barnes and Noble store is massive. It's huge. They redesigned the layouts in a lot of stores. They allowed the managers and the folks that run those stores to actually have like a unique design. So like they're like, hey, in Brooklyn or Upper West Side Manhattan or whatever, they're like, hey, the local clientele, the locals here, and they're like, hey, we'll give you tips on how to turn the table this way and make it angled this way so the flow, and it puts a person in a different experience. Long story short, they hired some executive that helped turn around other bookstores in the UK and other book chains over the years. So they hired this guy, I forget the guy's name. Barnes & Noble is back, and he was talking about, he said, Barnes & Noble, we got rid of the boring books. We got rid of the medical books and the other books that, you can just buy on Amazon, and I think he was kind of saying it's like those books are like transactional. He says, you can buy this book on Amazon, this nonfiction book. You can buy this nonfiction book on Amazon, and then you can also walk into this Barnes & Noble store and buy this same exact paperback nonfiction book at this Barnes & Noble location. And he was talking about the experience exactly how you're saying about the patient who knows they have free access to Sword Health or Hinge Health or whatever. They still drive, they get in their car, they put clothes on, they get in their car, they drive to your location, they park, they got to walk in, they got to check in, they got to pay a copay typically because of the human experience. And the CEO or then this executive at Barnes & Noble was talking about how someone can buy the same book on Amazon that they can buy in person, and they will buy the book in person after having an experience. Maybe they bump into another customer, and the customer is like, hey, like, you got that book? Like, have you read this other book by Tom Clancy or whatever? I liked it for this reason, whatever. And the customer leaves with the physical book in their hand, in their bag, whatever. They're leaving the store, and the Barnes & Noble executive is saying it's the same exact book, but it's a better book.
Yeah.
And I was like, whoa. As soon as I saw it last night, I'm like, somehow I need to bring this up with Tony, and you just put it on a tee for me, because now I feel like I know you said there was a middle ground, but it seems like for whatever reason, you're sipping my Kool-Aid a little bit more. You're going away from the timed units and insurance and all that, and maybe you're going to some middle ground, and so maybe we can meet in the middle. I don't know.
No, I agree. I love the Barnes & Noble story. I researched Barnes & Noble a couple of years ago. I knew about the new CEO that they brought in. An interesting fact about Barnes & Noble was the reason they didn't go out of business when Books A Million and all the other bookstores went out of business. They actually owned their real estate. And so their real estate portfolio was appreciating. That was keeping them around during the Amazon explosion and all the book sales going online. What I'm looking at for 2025, kind of what you're alluding to, is, okay, the science is a commodity. The exercises, the reps, the stuff like that, the treatment protocol, all of that stuff can be free online. Like, there's no value in that anymore. And that's why Medicare is not paying us more. That's why our reimbursement isn't going up, because we should be able to, and this has been my argument for a decade, when I was a new grad, it was more expensive for me to treat a patient after a rotator cuff repair than it is today, because today I've got 20 years of experience. I've got a lot more knowledge. I can see things that are going to happen before they happen. Why is it costing the same to rehab a rotator cuff repair? It should not. We should have compressed all of those prices down to virtually zero. What I'm doing, the Barnes & Noble experience versus the Amazon. Amazon delivers the book tomorrow. Barnes & Noble, you have the smells, you have the sights, you have the sounds, you have the chairs, you have all of that. That's the newbie. That's the soft wave. That's the rehab reactive step trainer. Like, that is the equipment that I'm investing in right now to deliver that premium experience. Jerry Durham talks about Starbucks creating the third space. It's not home. It's not the office. It's a third space. And I always thought about that. I'm like, I can get a great cup of coffee on the corner. Why am I going to Starbucks for an average cup of coffee? Because of the experience, because of the design. That is where the profitability is for us moving forward.
Yes, and I was just about to swing it back to profitability, because Alex Hormozy said something like Starbucks, the lifetime value, I think I mentioned on the show before, but do you remember approximately the dollar amount of the lifetime value of a Starbucks customer to Starbucks?
No.
So how much one customer on average will pay over, basically, like, from when they started going to Starbucks until today? It's like $14,000.
I would have said $600. Okay.
at like, $4 to $6 at a time, which is wild. And that's because they have scale. They have so many locations, and you can stop in any place. And usually it's like a consistent, you say, grande, this, that, whatever. And it's usually, pretty consistent, because they got some of the, fast food type of components in there for efficiency and consistency and all that. But yes, profitability. So again, it swings right back to it. I was just about to say it. And if the practices don't have this in physical therapy or healthcare or whatever, you can't have that type of an experience. That would be the Barnes & Noble example. Like, why would someone skip Hinge Health and Sword Health that's free? They can do it on their computer, assuming that they have a little technical skills. Why would they come to your location? And then, even in Ohio, there's, I think, is Dennis, is Cameron Dennis, is he out of pocket? Like, there's other people that are out of pocket in your area.
Right.
So it's like, they're also nearby residents that you said on a previous episode recently that that there's people that would pay out of pocket for your type of services, your type of an experience. So it's just fascinating to break down and talk about.
All right, we're coming down to the last little bit here. Predictions. Medicare coverage. So they're saying, big news. Medicare will probably, I'm putting my words in, probably expand coverage of virtual physical therapy. We've got remote therapeutic monitoring again. I think it's going to continue to grow. I think it's going to continue to be more widely accepted. I just interviewed Stephen Cohen again from Sarah Health. I haven't made that interview public yet, but we were talking about, finding those new ways to roll out relationship building. And so Sarah Health just released an option where I have a welcome video. So when I add somebody to the Sarah Health platform, the first text that goes to their cell phone is a link to YouTube with my welcome video. Now, that was something I used to do years ago. It kind of fell off the radar, but they're bringing it back. And then he said, patient perspective, patients will increasingly be warming up to virtual PT. I am still shocked, even with my biases, at how many patients see no issue. They're totally used to, they'll literally be in my clinic and they're like, oh, I got to take this call. It's my endocrinologist who's doing a virtual consult. And they'll literally go out the door and jump on a video call with any kind of MD specialist. I think we are more resistant to that change than the patient is resistant to that change. But to your point, all they're doing is they're going out there and they're being told information about their tests and their labs. They're not being treated. So I get what you're saying.
Yes, because I disagree. Okay, here I got a couple examples right before the holidays. I don't think I mentioned on the show, but very smart client of mine. He's like one of the two clients that I'm treating right now. He's he's an attorney for one of the gigantic, like the big four, like the big four accounting firms, very intelligent. And we discussed telehealth briefly, physical therapy, telehealth. And I don't want to say too much, but he's got like a neuro component and he's got like a couple orthopedic components. And we talked about telehealth for a second, and he goes, "How could you do that?" And that's someone who is very intelligent. I think he went to Columbia University, and I'm not saying like if you're intelligent, like you, I don't know, like, but that's a consumer who is very savvy. They make a lot of purchase decisions, with their spouse. They understand. They have a certain perspective of the world. And how can a physical therapist like me? How can I try to sell something when I believe a lot of my target population is going to say in their head, like, how could you do, because some of the therapy visits that I've done with him is hands-on manual therapy, or it's contract relax, or it's tactile cues, and it's things where I'm guarding him if we're doing balance or whatever. And so he's like, how could you do that? Like, how is that even possible? So it's like, how can a physical therapist pitch or sell a a covered service of telehealth or out of pocket, either way? But even when it's covered, it's like a lot of the population has a predisposition. Like, how could physical therapy be done over a video visit? And you're going to just tell me what exercise to do in a chair, like, and how can that be worth my time?
Massage robots. I remember Rob Vining always used to share a GIF or something of a robot with lasers coming out of his eyes. This is going to be my go-to, massage robots. No, you're right. Like, and again, what you sell, who you sell it to, what they're looking for. That's the most important part in all of this. Barnes & Noble is not going to put Amazon out of business. We can all agree on that. Amazon will continue to deliver books the same day or the next day. Barnes & Noble will continue to deliver the experience of buying a book. Barnes & Noble slows down the process. Amazon speeds up the process. Like, there are people who want both of those scenarios separately. And the beautiful part is we have the opportunity to deliver. Real quick, moving away from all of this, this is the craziest thing that keeps coming up in my news feed. And we'll wrap up with this. Gary Vaynerchuk, which I'm a huge fan. I've been following him for a decade. He keeps pushing TikTok live selling. Have you seen any of this or looked at it at all?
I didn't know he was talking about it specifically about TikTok. I have seen that he's been posting a lot about the future, like this year, having a lot more of this, basically like a live, home shopping network kind of thing. Gary is super successful. He's very successful. He's very motivated. But at the same time, 4, 5, 6 years ago, he was saying the same thing about Amazon Alexa. And I told you guys on the show, he was completely wrong about Alexa. He said Alexa was going to replace Google search, and people were going to be, saying to Alexa, Alexa, what's the best physical therapist near me? What's the best barbershop near me? How much do they charge? What's their soonest availability? Alexa, find me a locksmith, whatever it is, a roofer, whatever. And literally no one uses Alexa for any type of search where you're trying to get something, you're trying to hire a professional, or you're trying to problem solve something in the real world. So I'm not that interested in it, because I've seen the effectiveness of QVC and the Home Shopping Network and some of those. And unfortunately, my mom is a big shopper of those platforms. And they use all the marketing tactics, the scarcity, we got 2 seconds left, we got 5 minutes left, we had 40 units remaining, now we only have 3 units remaining. Get them while get it while it lasts. And I'm sure there's like a stockpile in the factory that has thousands of units available. So yeah, I've seen it. I don't understand, I guess, fully, like, what's in it for him. Why is he pushing it? Like, is he going to have some platform that comes out that hosts a lot of this stuff? I don't know. Or it's just his his interest in like selling, because he's done all the yard sale stuff where he films himself. He goes to someone's yard sale in New Jersey and he tries to haggle with them, and they say $10. And he's like, how about 2 for $5 or whatever? Like, and he's like a multimillionaire and he's like haggling for pennies and dollars. He does that for content. I don't know. Maybe he's just doing this for content.
Yeah, I don't know either. And I agree. It's a weird, awkward, uncomfortable experience to like watch some of these. And it is a completely different culture than I think anything that I'm used to, probably you're used to. But I was thinking about this and I'm like, how do we adapt something like this? I watched a couple of videos that talked about how TikTok is really pushing these live interactions, live streams. What's interesting about TikTok Live is they don't archive that content, where here we're live. This is live right now, and YouTube will keep this available in perpetuity. TikTok doesn't do that. So I could see, and I've seen ridiculous numbers from TikTok shop affiliates and stuff like that. Like these people are making tens of thousands of dollars a month doing these live selling events. Amazon has it too. It's just not as popular on Amazon. But where I'm going with this, I'm like, my dream has always been to be able to stream live from my physical therapy clinic during patient engagements, so that obviously I have consent, it's informed consent, HIPAA compliant releases, all of that stuff in place. But to have a real patient who's going through a real recovery process, post-surgical knee replacement, and stream it live. I've done it with PT students, and I think it's a phenomenal experience. So to be able to do that with the general population, I think there's a huge advantage to that. And again, these could be people in other countries that will never have access. They will never be my patient. I'm not getting paid for any of this. It does get monetized with ad revenue, I'm sure. But the idea is it's a way to expand access to care, to share new ideas, to share different perspectives about a condition that you and I probably treat very differently, but not right or wrong, just different. And I think there's value in that. One more form of virtual PT. All right, let's wrap it up. Parting shot. What's on your mind?
Let's see, with the Larry stuff, with the Larry Benz predictions, AI anxiety. By the way, we didn't even cover that. There's not going to be much change in the physical therapy world with AI. We talked about this. So I don't understand, like, how is that causing anxiety? It's going to help you with documentation, hopefully. It's going to help you with practice management and running reports, hopefully, with Prediction Health or some other platforms or whatever. Maybe Sarah Health is going to add some AI and just automatically take your texts and your exchanges with patients and automatically sync to your medical record and bill those claims and those units or whatever. But I really want to double click on my parting shot. I really want to double click on what you were talking about around the value base and the experience component of what we offer, and less so the timed units and, I got to do something for 3 more minutes so that I can, bill a 4th unit or whatever. That is, I think that's the future, or it's the present and the future of physical therapy, which is the experience, which is the in-person. Maybe it's some hybrid stuff. Maybe it's some component of telehealth. You have an in-person experience and an in-person relationship with Tony or whoever your physical therapist is. And in between, maybe it's text messages, emails, video chats, phone calls, whatever it is, and tying those together. I don't see how that's ever going to change. Just like that robot that you showed, that will never replace massage therapists. There's always going to be people that pay to go to a massage therapist. That robot will never replace. And the people that want the robot because it's a $20 massage or whatever, those are different consumers. Those are the folks that typically will say, do you take my insurance? And then there's other folks in the world that are going to pay out of pocket for that massage or the physical therapy or whatever. So those are the people that we target with our service.
Awesome. My parting shot is simple. Guys, it's a new year. Go support the Dave Kittle Show. Find him on YouTube, subscribe, follow the podcast, go to PT Pintcast, like hit all of the socials. Your support is what keeps us going. Like Dave and I take time out of our day. I'm in the clinic. I've got patients waiting on me. We want to share these ideas to help everyone. The best way to support us is go out and subscribe. Dave, I'll catch you on Tuesday and Thursday, 8:30 a.m. Thanks for joining us, guys.
Thank you, Tony.